Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Sandeep Kumbar, gastroenterologist at Suchi Rayu Hospital, Hubli, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective, evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
Hello, my name is Dr. Sandeep Kumbar, gastroenterologist, hepatologist, and therapeutic endoscopist working in Suchi Rayu Hospital, Hubli, Karnataka.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
So, IBS is nothing but irritable bowel syndrome. So, it is actually related to digestive tract. So, in simple terms, for example, if a patient is suffering since long time, for example, around 6 months, he has abdominal pain followed by change in stool characteristics in terms of loose motion or in terms of constipation or in terms of incomplete evacuation of bowel. So that is, in simple words, we can tell that is an IBS.
Why do you think IBS remains one of the most underdiagnosed gut conditions in India?
IBS remains one of the most underdiagnosed because patients, first of all, don't understand what exactly they are suffering. They usually tell you non-specific symptoms and they don't know which doctor they should visit for their symptoms. So for that reason, it gets delayed, and a lot of doctors themselves doesn't identify this as a disease. So they just think could be a non-specific symptom, and they might just prescribe local painkillers or some placebo medicines. So that's the reason it is being very underdiagnosed. There's a special criteria for diagnosis, and you need to spend a lot of time with patients to identify how exactly IBS behaves and how you have to tell the patient.
In your experience, how does a typical IBS patient present in an OPD?
So in my experience, typical IBS, usually we don't get it. As per the definition, it usually comes with abdominal pain and then it relieves by after defecation. That's exactly how IBS behaves. But a lot of people will come bloating, just beyond bloating, what we call, and then they say that I have a pain and sometimes I get relieved after defecation, sometimes I don't get, but I keep on having a pain which sometimes comes in the evening, or sometimes it comes in the morning, or sometimes after the food. So these are the commonest IBS symptoms we get from the patients in our side.
What are the biggest myths or misconceptions you hear from patients about IBS?
Biggest myths or misconception about what I hear from the patients is all about that they think it is a serious disease and they get more of anxiety, and then they get more of, they involve in a lot of, psychological conditions like depression, and then they feel that no doctor is identifying the symptoms. That is a major reason what the patient is having a misconception. And then that's true also because a lot of physicians or doctors are not able to identify exact IBS symptoms and then to deliver the patient that what they're suffering, and then we need to understand the symptoms and then give them a proper directions. So that is not happening, and that's what is a major misconception in patients.
Is IBS really a stress disease, or is there more to the story?
I really cannot say only a stress disease related. It is also related to your lifestyle, your food relations, a change of place. Stress is a part of a disease actually. So definitely there is a more story to it, but stress will worsen. Stress, if you don't address it properly, it might lead into a long-term disease where patients keep on shopping the doctors until unless they resolve the stress issues.
How does modern lifestyle food habits, stress, and sleep contribute to IBS?
Obviously, lifestyle, food habits, everything has to be in a place. These IBS patients have a very weird lifestyle, haywire lifestyle. They do not eat proper timings, and they do eat a lot of foods which they don't tolerate it. Because IBS is sometimes we call it as their intestines are a bit more sensitive to certain foods which are not able to stop it. So they keep on having without their knowledge. Stress, definitely a lot of IT industries, a lot of sedentary jobs having a stress related issues. personal or a profession, they have to address it. Sleep, definitely 6 to 8 hours sleep is a must for any individual. In fact, need not be an IBS or non-IBS, but sleep definitely defines an IBS patients how they are going to have long-term disease definitions. These are all factors which affect IBS.
What simple screening questions can a consulting physician ask to suspect IBS?
IBS, actually, you just can ask whether the patient is having symptoms since last 3 months, and then consistent symptoms since last 3 months, and then it's ongoing since last 6 months. And something like abdominal pain, which is associated with change in bowel habits in terms of constipation or loose motion. So these are the classical symptoms of IBS. Actually, we can also ask them about the red flag signs, like do they have loss of weight, loss of appetite, or like how the change in bowel habits in terms of whether they have a blood in stools, and they're having a fever, they're having a lot of other factors which might not be an IBS actually. So we have to ask all these questions to the patients.
How important is the patient's history compared to investigations in IBS diagnosis?
IBS is basically diagnosed in terms of history only. There is not much of investigations to add on to the diagnosis actually. Investigations we do just to rule out other causes of his symptoms. IBS is exclusion diagnosis, where we diagnose only on the basis of clinical history, clinical symptoms and duration. So definitely history is the main role here in diagnosing IBS.
What are some common mistakes in diagnosing IBS at the primary care level?
First of all, common mistakes usually done at the tertiary or secondary centers, or just giving a symptomatic treatment for this. We don't address their proper symptoms. We don't understand their pain, or we don't understand their symptoms since they're suffering. We just prescribe medicine for them at the tertiary level in terms of painkillers or symptomatic medications, and then they keep on coming back, and then they understand that if they keep on coming, they think that this is they're suffering from some big disease. So they go into that loop, and then they keep on doing the doctor shopping, and then they finally understand that there is no cure for this disease. So they come to conclusion where they start having depression, they start having a lot of issues in their psychological condition. So that's a major mistake usually done at the first center.
Are there any warning signs where a physician should immediately refer to a gastroenterologist?
There are a list of foods. We don't know which patient has a tolerability to which food. For example, we use something called as low FODMAP diet. Patients can go back and Google and see what is low FODMAP diet, FODMAP, which we tell them at least 5 to 10 foods in their daily habits to avoid for a certain period of times and see how they feel. If they feel very much better with those foods, and then definitely that food has triggered them. So something like apple, milk, or sometimes foods like onion, garlic. So these are a certain very commonly used day-to-day life in every patient.
How often do you see IBS overlapping with anxiety or depression, and how do you address it?
I see very oftenly IBS associated with anxiety. Every 5 or 6 patients out of 10, in fact, more than 50% is associated with anxiety or depression. That is mainly because of their work pattern. There's loss of sleep, a lot of professional and personal problems, and then the childhood, some trauma event or abuse, which can have this IBS symptoms actually. So we address it by, it's a holistic approach, it's a combined approach. Drugs may not work alone. We always counsel these patients in a session wise, and we give certain, drugs which can handle this anxiety and depression. And then overall we have to control with it food diet, food habits, lifestyle changes. Everything has to come in place to manage this anxiety and depression.
How do you tailor treatment between IBS-D, IBS-C and mixed IBS?
So basically, as you mentioned, that IBS-D, C and mixed are 3 components of IBS in patients. IBS-D is nothing but diarrheal variant. That means patient is passing more than 3 times a loose consistency of stool actually. So that is usually we address it to certain medications and change in diet. Constipation, we like IBS constipation, usually it comes with a pain and then followed by constipation. Certainly it differentiates from functional constipation where there is no pain in the abdomen. Mixed is a mix between diarrheal and constipation. So treatment is a bit different in diarrheal variant constipation, where we give a lot of anti-diarrheal medications here along with the rifaximin, along with the pre-probiotics, which I'm going to talk might be another question there. IBS constipation, we give the certain medications to relieve the constipation, to get the confidence of patients that it's a treatable actually. Mixed is a mixed variety of drugs which we give, and then it's more of a trial and error combination.
What's your opinion on the role of rifaximin in IBSD? Where does it fit best?
It's actually one of the treatment of choice in IBS diarrhea. Rifaximin we give around 1200 mg for a period of 14 days, and then depends on repeating a lot if patient is 50% or 70% improved. Invariably, a lot of patients will respond to 1200 mg of, that is 550 mg 2 times a day dose of IBS diarrhea. It's one of the best because it changes, it's a non-absorbable antibiotic in body. It doesn't goes into the blood, no side effects. So it's one of the best fit medications in IBSD.
How important is patient counseling in IBS management? What key messages do you give?
Counseling is an important part of IBS management. We need to spend at least 15 to 20 minutes with all IBS patients, otherwise your management will be incomplete. We have to understand their pain. We have to tell them that whatever the suffering is real. They feel that the doctor is not able to understand and then just writing the medication. So we have to tell them, the patient, get into the confidence that we understand their pain and it is real. It's just that they're not suffering from some life-threatening diseases, and it is a treatable, just change in lifestyle, change in food habits, certain drugs for a certain period of time, and then cognitive behavioral therapy, some counseling. All these things will definitely help. And that is the key message, is we have to understand their pain, tell them that we understand and there is a treatment for this. This is a key message which we can give to the patients.
Do probiotics or prebiotics have a role in IBS treatment?
Probiotics and prebiotics have a huge role in IBS treatment, especially IBS diarrhea, where we give it for a period of 3 weeks to 4 weeks, and then we can taper it off for the period of time when they respond. Just because IBS is one of the disease of where there is an alteration in the microbiota in the intestine. Usually we have a different microbiota. That means we have a good bacteria, we have a bad bacteria in every individual. So when there is an imbalance between this good bacteria and bad bacteria, where the bad bacteria scores over a good bacteria, that population becomes much more than good bacteria, and that's where the IBS sets in. So pre-probiotics will help in making them balanced proportions in IBS patients. That's why it plays a huge role in management of IBS, especially diarrheal variant.
How do you balance pharmacologic and non-pharmacologic management approaches in IBS?
There is always a good balance between a pharmacological and non-pharmacological management. Majority patients need a little pharmacological management and a lot of non-pharmacological management in terms of food habits, like what to eat, what not to eat, what to avoid for a certain period of time, or a change in sleep habits, a lot of relaxation techniques, a lot of counseling, how to come out of anxiety, and how to use anti-anxiety drugs, antidepressant drugs for the period of time. All these are non-pharmacological management. And we have to balance in each and every patient. Some patients may not need a pharmacological management. Some patients need a lot of pharmacological management. So it depends on patients to patients.
How do you handle a patient who doesn't believe IBS is real?
It's very difficult, in fact, but at least 2-3 visits, they should be able to understand that this is one real irritable bowel syndrome, is a kind of a disease where it's not life-threatening. So what we have to make sure that for the patients that it is not a life-threatening disease. And sometimes you have to live with it and, you know, understand the disease and go ahead. Once they understand that it's not life-threatening, it just stays with them, and they know how to control over it. I mean, that they will believe that it is a real disease, and then understand and then they follow our advice.
How do you simplify IBS counseling in a busy OPD setup?
It is, in fact, a difficult job because IBS patients need more than 15-20 minutes, which is definitely different from other disease variety. So we are doing a separate IBS counseling where we keep psychologist and a psychiatrist for the same. We understand that IBS patients need a little bit more time, a little bit frequent visiting consultations to get the confidence out of them, to make sure that they understand the disease and then they overcome. So that is where we keep as a separate day or separate OPDs for IBS patients.
What's your message to young doctors who hesitate to label a case as IBS?
Actually, of late, a lot of doctors know how to treat IBS. In fact, it's just that it's a broad aspect. It's not a single entity where you have to write the drug and then treat it. It's a holistic approach, as I already told you. We need to address each and every problem, and then only it is able to solve. So what I advise for young doctors is sit with the patients and listen to them exactly. what they want to tell you, and then tell them. If you don't listen to them, then they don't come back to you, and then they keep on visiting other doctors, having a partial treatment, and at the end of the day, they won't come back or they don't get treated properly. So always I advise young doctors who are young gastroenterologists just to keep calm and listen to their history, and then try to tell them that each symptoms they understand, each symptoms they try to correlate with their IBS, try to tell them that this is how it works, this is how it happens. Then only they can deliver a proper treatment or management, and then only the patients can understand that, oh, this is IBS, and then I'm at the right place. So something like this.
What's your vision for IBS management in India over the next few years?
The vision of IBS management is in India over the next few years, it's going to be increased only, just because of a lot of change in lifestyle, a lot of change in food, processed food, sedentary lifestyle, a lot of stress which is related to profession and personal. So in coming few years, there will be definitely going to be a surge of IBS patients. It's just that we have to properly diagnose it.
One food you tell IBS patients to avoid?
There are a list of foods. We don't know which patient has a tolerability to which food. For example, we use something called as low FODMAP diet. Patients can go back and Google and see what is low FODMAP diet, FODMAP, which we tell them at least 5 to 10 foods in their daily habits to avoid for a certain period of times and see how they feel. If they feel very much better with those foods, and then definitely that food has triggered them. So something like apple, milk, or sometimes foods like onion, garlic. So these are a certain very commonly used day-to-day life in every patient in Indian scenarios, where we can tell them to avoid and see whether they will improve or not.
Thank you, doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.